We're going to talk about brain tumor treatment trends. I have nothing to disclose. We're going to talk about we can arrive as a collective wisdom of a great plan of care for the individualized patient without first understanding the goals of care. And they're broken down into things we do to help symptoms, things we do to help the tumor treatment, and the balance, the secret sauce, is balancing the risks and symptoms of the tumor and the risks and symptoms of the treatment. Another way to describe that is pictorially. We all want to provide care, but along someone's lifelong continuum, we balance what are we doing to slow down the growth and the burden of the tumor with what can we do to support someone's quality of life, symptoms, and safety. And I put the word palliative care there to describe that the Latin term pallin, or a Roman soldier's cloak, a pallin, back in the day before traditional medicines, often clothing and warming and sheltering was some of the best health we could do, and still today it remains. Another way to describe that is individualizing each individual patient's journey. My analogy is to say that we begin a novel together. You're not a book, a publication, a blog. You're you, and we want to help you live your longest, best novel. So if I line up 4 people that have a similar tumor in a similar place, they have very different times in each treatment chapter. And that's what we're here to talk about today, is optimizing and individualizing. But the binder of that novel is one's quality of life and health. We always think as physicians it doesn't matter if there's a cool, sexy vaccine out there if someone's not well enough to want it or well enough to get it. So everyone's quality of life and symptoms are integral. So we're going to talk about 3 trends: surgery and invasive procedures, medicines and devices, and symptoms. Neurosurgery advances are really Star Trek cool. Tremendous neuronavigation, computer equipment, helping the surgeon do what they want to do and have the least potential impact on structures they do not want to touch. And this is just an example of some of the very, very highly technical skills and equipment that surgeons are using, and it takes a team. What that does is empower decision making, and we're going to talk about some case examples in the future. And these are just examples of planning that can be done with computer modeling. And now neurosurgeons can actually put treatments into the brain tissue or the cavity or into the cerebrospinal fluid. This is an example, one of our patients that allowed us to use his photos. This wonderful gentleman became wheelchair bound from a 4th recurrence of a glioblastoma, and a resection that was carefully planned by the surgeon to make sure that he could find a way into the brain tumor that did not harm critical structures and be able to remove what he could safely, lower the need for steroids, etc. This gentleman was able to go from being wheelchair bound to being able to walk and work full time without the use of steroids. So that's an example of very highly precise surgery. We were also able to get tissue that allowed him to be part of clinical trials. Another example are clinical trials that we have here and elsewhere that actually take people's tumor tissues out and actually then take it with their own individual immune cells and make an individualized vaccine that we can give back to the patient with their own immune system cells fighting their own individual tumor. There's also radiation advances. The pictures on the right describe or show some of the ways we can do radiation. It is energy coming from the outside in, and it is fractionated. It can be fractionated in a few doses, often called radiosurgery, or it can be fractionated in many doses, and that's traditional fractionation. And so this would be an example of different types. A lot of people have heard about proton therapy versus photon therapy. And the key message here I want to just describe is that photon and protons work the same where you want to target them, but it is how much shine through or scatter or extra radiation beyond that that often we will play to the advantages of do we want that or not. The picture on the right those are pictures on the side of a child. And what that's showing is the target of where you want the radiation and where you don't, and how to pick the right type of radiation. Many in the room have heard about stereotactic radiosurgery, and that's using external radiation with surgery-like precision with arcs or beams to be able to get the maximal radiation where you want it and to divide up the radiation where you do not want it in a surgery-precise way. And that type of precise radiation is being used in the brain and the body for different tumor types. Highly precise advances that are making treatments work better with less side effects. And there's a few other radiation advances that you may have heard about, and one is called the abscopal effect. And that is that if we do radiation in one place and potentially use immune therapy or chemotherapy, by creating a tumor cell kill and creating awareness of the tumor and a disruption in one part of the body, we can actually make treatments and the own immune system fight that same tumor elsewhere. And then the picture to the right shows that the radiation doctors are becoming increasingly able to avoid structures such as the memory zones when we want to avoid them. This is an example of a case of a patient that has a melanoma metastasis in a very, very difficult place that is very hard to do surgery with potentially side effects. And this is laser-like precision radiation that was able to melt that tumor away. This is another example of a different type of radiation strategy, another very difficult to get at tumor spot by a surgeon, but by radiosurgery could melt that tumor away. I'm going to transition and talk about medicines and devices. One of the biggest things that has happened to medicines is the way we can deliver them. So we think of IVs and pills, but now we have patches, sub-Q vaccines. We can even aerosolize medicines, and we can even put them in different body cavities. So wonderful expansion of how we can give medicines. And then clinical trials are an increasingly important part of patients' care from diagnosis and each of their treatment chapters. And I put this in for reference to describe that there's different types of trials and there's different phases of trials, and they all have a different goal. So when you are working with your treatment team, you want to have a conversation of if there's a trial that may or may not be a fit at any one of your treatment chapters, and if so, what type and what phase might be available or appropriate for you. And we think about how to start treatment. Well, there's sort of ground rules for starting treatment. We just talked about the fact that there's medicines and surgery and radiation. And the concept to get across here is that your treatment team, your care team, is going to put up on one level playing field things that are equally likely to be safe and to work to the best of our ability. But then it comes down to logistics, your goals, your wishes, the needs of a caregiver. Is it a pill? Is it an IV? Where do you get it done? That's equally important. And then when you're on a treatment, there are many tools to help us decide how are you doing, should you stay on that? Imaging, your goals, your wishes, your quality of life, your labs. And then there's always stopping rules, getting from one chapter to another. So we think about them as, do you want it? Is it safe? And is it getting the job done? And those are very, very important, and every patient and their families are equal stakeholders in answering those questions. If we reach a stop, we can go on to another treatment chapter. This slide is going to be cartoons to describe that there are myriads of medicines with different mechanisms, different goals, and the opportunity in oncology now is to find the right drug at the right treatment chapter, how to sequence them, how to know when to start them, how to know when to stop them, how to know when to combine them. And so a few examples, and one that everyone has heard about, is immune therapy. So let me share in my own words how I put that together. I think of the immune system as much like our special forces, our armed forces, Army, Navy, Air Force, Marine. Could be the different types of white blood cells and the different types of cells that we have as immune fighters in our body. And what the immune system is challenged to do every day, whether it's a rusty nail in our finger or a virus or a tumor cell, is to be able to identify an offender, not a like self cell, but an offender, an unwelcomed offender. Then to be able to present it to the people that can do something about it, the effector cells, like T cells. Then to develop a specialized response to that offender, magnify and optimize that fight, and then just as importantly, know when to quit, know when to turn it down. And that's really what the immune system is doing, and that's what immunotherapy in tumors are trying to do. And so let me give you a few examples because they're important and they often require tissue and they require testing to be able to utilize. This is an example. CTLA is a receptor. And what that receptor is a break, a natural break on our T cells that allow that mandate that we have a double check system to make sure that we have a co-stimulation of our T cells before they really know it's an offender and they really want to start a fight. And what that does is actually actually, it's like a brake system. So by blocking that brake or putting an antibody on that brake, we can unmask the T cells to better recognize the offending tumor and unleash that tumor treatment. So it's by blocking the block that allows the body to fight that tumor. Here's this in living color. This is an example of a gentleman at the top with metastatic melanoma. It's also in his skull and in his brain as well. And that's one dose of that drug. And that basically allowed his body to fight that melanoma in a very strategic way. This particular drug does not require tissue testing, but some do. And it requires a long time for the T cells to work. So it's something we can't always use if there's a certain scenario in the body, like a heavy burden of disease or a disease in a place that's close to a structure we don't want to irritate. The pictures on the bottom are to describe that traditional chemotherapies and many of our newer therapies delay the time that the tumor comes back. What we're finding with immune therapy is there is more patients that it's not coming back in. So not just pushing out the time of progression, but actually lowering the number of people that progress. And this is an example of an alternative way that the immune system works. Tumor cells inhibit the body's response by binding to certain cells, basically tricking our immune system not to fight it. But by putting an antibody on that trickery, we allow then the body to recognize the tumor and the T cells to recognize the tumor cell better. Example of that in proof are drugs that listed there. They also take a while to work, a while to get the immune system to rev up. And that's an example of something that does require tissue testing, either in the brain or spine area or in the primary tumor. And these are some pictures used with permission with our BMS colleagues and at presentation at many educational locations. These are examples of brain metastasis patients. This is a non-squamous cell lung cancer patient with brain mets who had their brain mets go away with this therapy and stay away for quite some time. An alternative type of lung cancer, squamous cell lung cancer, brain metastases, tumors responding to this therapy. These drugs were first thought to be so big and irritating they wouldn't get into the brain, but they do, and they're active. And this is just a third example of metastatic melanoma. A patient underwent a combination of those therapies and had a dramatic response in the brain mets. And this is an example of the dramatic reduction that can happen in the body as well. You see pictures of MRIs on the left, and then the actual pictures on the right. Dramatic response to those drugs. Another mechanism is a different type. It is a mutation that happens within the cell in which the cell then has unregulated growth. And we also have drugs to therapies like this called targeted agents. And the picture on the right describes a two-step approach where we can take that type of mutation, find an antidote drug, and that is making great impact in a lot of different types of brain and spine tumors, used in primary as well as metastatic tumors. Another example of a type of drug that requires tissue testing. And now another advancement is precision medicine. Instead of taking patients that look alike on paper, giving them one drug and seeing how they all do, can we be more precise with therapy and individualize with precision each treatment? This is an example of precision medicine, combining different therapies in unique and individual ways to have an improved outcome. Chemotherapy, targeted therapy, immune therapy, in a combinatorial fashion to help people live longer and better. Many of these precision techniques require tissue testing or fluid testing. And so that raises the importance of having patients get care in places where these things can be done. They can be done at institutions, they can be done by private companies, they can be done as part of a clinical trial. But not only does that help us make us smarter about how to help people pick the right treatment, it can often identify a drug we were not otherwise aware may be a good drug for them. And so a few examples. This particular picture is to describe the fact that sometimes patients with certain disease processes, with certain markers or certain mutations, can change during their treatment chapters. As the tumor mutates, as the tumor spreads, the markers can change. So the goal of testing is very important because someone that may have an ER positive or HER2 positive breast cancer and it goes to the brain, it may no longer have those markers at the time you have to fight it in that area. And this is an example of a different type of precision medicine. This is an example of a pituitary macroadenoma that melted away with the use of a drug for which we found a specific tumor marker, MGMT methylation. And that's a drug that we also use in different types of tumors. This is a different example of finding a precise mechanism of action, angiogenesis, in a tumor process called neurofibromatosis type 2. And that is where people have tumors along their hearing nerves. And so by using a particular targeted drug, we slowed down hearing loss, slowed down the growth of tumor, and in many cases we're able to optimize therapy. This is an example of a patient that's had about 5 or 6 different chemotherapy strategies and about 4 or 5 different radiation and surgery strategies for a recurrent meningioma. And the value of this is at one of the surgeries we did tissue testing, and we're able to find that they had certain markers, and we exposed them to those drugs, and he had a dramatic response in tumors in areas that would have been very, very difficult to get at in any other way, and for which there was no radiation role anymore. Significant improvement by finding a right drug and right target. I also want to transition and say there's been trends of advancements in novel trials. This is an example of a type of oral drug that is a novel mechanism of action in the metabolic pathway of a tumor. The type of tumor I'm highlighting here is an anaplastic astrocytoma, for which there are no specific drugs FDA approved. This particular drug has a unique ability to slow down the mutation in the growth of this tumor in early and moderate phase tissue testing. And so this is an example of a scientific curve here showing the treatment arm in blue above and orange below the standard arm, showing that patients with this type of tumor were living longer and better with this oral novel therapy. This clinical trial is a phase 3, which means we know a lot about its safety and its benefit, but then we are honing in on how much benefit and exactly the right recipe for this patient population. If anybody, if you or you know of, has an anaplastic astrocytoma or an astrocytoma, this is an excellent trial to keep thinking about maybe a fit in someone's treatment chapter, yours or others. I want to transition. The last part of this is about devices, tumor treating fields. Let's talk about that a little bit. So I want to just clear your mind a little bit and say we're on planet Earth with gravity, and all of our cells have a polarity and an energy. And that's how we actually make MRIs show us pictures, is using the polarity and the energy of each of our cells. And when we think about something like a prostate cell and it has to make PSA chemical, how does it know to get the chemical to the cell surface? Or when a cell wants to divide, how does it know how to divide and split to the side? There's an organizational structure, an energy, and a topography to cells. And by perturbing a tumor cell with a certain frequency of energy, the investigators of this type of treatment have been able to find that we can slow down the growth of certain tissue types, certain tumor types, by perturbing them with certain energy. So it's an energy biologic interface. Very interestingly, the same interfaces are what we use with chemicals, we can now use with energy. And so applied in a medical therapy is something called Novo-TTF, now Optune. And this is FDA approved for new and recurrent glioblastomas, and it's being used widely in other types of tumors. It uses a certain type of frequency, and when it's on, it's working. When it is not on, it is not working. And some examples of this in practical management. This requires dose planning, very similar to how the radiation oncologist doses traditional radiation, and it must be done by certified providers. But you can find a treatment center by getting on their website, a certified provider to make the plan, but it can be started at home and followed by community physicians as well. This is an example of it in recurrent glioblastoma. They took patients with recurrent brain tumors and gave them a choice of this device therapy or a best chemotherapy. And what it showed is that people had a similar response to the treatment, the device as well as medicines. They had a comparable overall survival, the device versus the medicine. But what stood out is that they tended to have a higher quality of life and higher brain quality of life, cognitive, emotional functions, global health. And furthermore, they had less traditional chemotherapy side effects. And the only statistically higher side effect was skin irritation, which many algorithms later we know just how to reduce and minimize. And so then that promise translated into pulling it into the new diagnosis setting of these types of tumors. And so people that undergo radiation and chemotherapy were randomized to also receive the device when they were done with their radiation and only on oral chemotherapy. And for those patients, it was shown that they had a longer time to progression, tended to live longer with the therapy as well as chemotherapy. And now with 4-year data, patients that had oral chemotherapy and this device therapy tended to live longer. So this represents the first device ever helping brain and spine tumor patients. An example of folks using this well and living everyday life was encapsulated by a documentary that you have here. One of our patients, a newlywed, found themselves with a glioblastoma, ultimately went on to use the Optune therapy in the maintenance chemotherapy setting, and actually became a champion of the Optune Buddy program, educating many patients and families about this therapy, and went on to live a very high quality of life and wanted to spread his story in these ways. And this is a good example of a life well lived. I want to highlight that this type of therapy is also in solid tumors of the body as well as brain metastasis. This is an example of a clinical trial for which there are rarely clinical trials in certain types of brain metastasis. This is using this Novo TTF or Optune device for patients with non-small cell lung cancer brain metastases. And this is available at our institution and many others represented here, and you can find more about it on clinicaltrial.gov. And very lastly, I want to talk about the secret sauce again includes symptom management and quality of life. So in closure, I want to just describe a few slides about how we're also advancing trends in the care using symptom management. We all know the symptoms, the diagnosis, and the late developing effects of people affected by brain and spine tumors. The key to this slide is the fact that whether or not the symptom is from anatomy and the function from the anatomy of the brain or spine, or it's from treatment-related side effects or general medical health, the goal is to have a treatment advocate, your care team, pursue reversible causes of those symptoms and treat them. Some examples of that would be when patients undergoing glioma therapy undergo treatment. So at the bottom x-axis is time, and on the y-axis on the left is inflammation, which can be a surrogate of tumor or treatment. And as you're going from the left to the right of this, you see the blue bars, and that's to represent a standard but individualized treatment. And so that treatment can be very much like going out in the sun, where you can develop a sunburn or an effect of the treatment before it calms down. And then later on, as you develop, people will have symptoms related to the tumor as well. But understanding the potential causes of symptoms leads us to come up with an antidote to those symptoms. And so a few examples would be treatment effect we often call pseudoprogression. It is an enlargement and an irritation of the brain tissue based on a treatment effect. So the pictures at the top represent a very angry brain that could be calmed down with aggressive symptom management. There's many, many other symptoms that I have no way we can talk about today, so that's why I wanted to leave them in your handout, and they'll be available at the ABTA website. But this is just a little inkling of the different medicines that we're now using off protocol and off label with evidence-based determination to make sure we are helping people's symptoms give them the highest quality of life. Pain, bone strength, rehab, all of these are integral in how well people are doing. I want to give one or two quick examples. Sometimes people are suddenly unwell and it's a plumbing problem. The cerebral spinal fluid gets backed up. We call it obstructive hydrocephalus, or sometimes it's communicating hydrocephalus. Different patterns of the brain plumbing not working. And by invasive procedures, people can get rapidly better. This is an example of one cutting out an area of an inflammation where the tumor is no longer alive but dead can dramatically make somebody feel better. In this particular patient, we were able to confirm that that area that you see on the left was completely treated. That area was dead but inflamed, but by taking it out, we did two things. Made that gentleman feel better, but two, did not did not falsely think that that was a recurrence of tumor and get him onto a different therapy that he no longer needed. So different ways we can help symptoms. I want to close the last 2 or 3 slides on saying that a multidisciplinary team is essential. Getting your home team throughout your treatment novel is absolutely essential. And that team will be composed of different people at different treatment chapters. So there are many, many things that you want your team to be able to do. So on this list are things that I am asking you to consider. May these things be right for me or my loved one? How can I find these in my community? The ABTA, other statewide programs such as the Southeastern Brain Tumor Foundation that we have represented here, and many, many, many others are depots of resources that help draw patients and families to these types of resources. Telemedicine and technology. You want your doctors and your hospital systems to do everything they can to bring as much care to each other and as much care to you. There are many patients and caregiver assistance programs, many different ones from government, pharmaceutical companies, private and nonprofit organizations, but please utilize those resources to bring added value and comfort to you and your loved ones. And this is just an example of some of the spaces we've created through donor dollars and partnership with our cancer center, is to create destination centers that when patients are getting care, they can get care in a place that is also kind and hospitable. This is in our brain tumor center, a cleanly built location that patients can come for hours. We can have family conferences, educational meetings, people stay there between procedures, etc. And they're all built so that we can have other providers and study coordinators, etc. come. And so lastly, through our partnership in the room and the extend and reach beyond this room, we are helping people live longer and better together. And I really appreciate the opportunity for you to hear the advancements that you'll hear throughout the rest of the day. And I want to thank you for all of your time.